Kia ora. Good morning, everyone. It's really a great delight to be here in New Zealand, and it's such a lovely country and such a lovely town. We have been discussing yesterday about potentials to bring in brain stimulation to addiction medicine and psychiatry. And today I'm going to talk about another topic that might be interesting as well. So we'll discuss about those things. But let's start from this point, that how is our success rate in addiction treatment right now? When we talk about different sorts of psychosocial intervention in addiction medicine, if you take a look inside of what we already have, you can see that the success rate is quite low. And even for CBT, that we have the highest success rate, it's really diverse in terms of the studies that reported the success rate for CBT in substance use treatment. And when we talk about different substances, we know that the success rate, especially for polysubstance users, is really low. And we know that most of the patients we receive in the clinic, they are polysubstance users. That is, those who are in the clinical practice, they know that most of the patients, they use everything. They use every drug that they can. So if I want to just give you sort of percent about our success rate in addiction treatment, it's something like 31% to have a meaningful abstinence for something like 3 months. And if we are going to do nothing for a treatment seeker patient, then the success rate would be something like 13%. So the effect of placebo or nothing would be something like 13%. So the difference would be close to something like 20% difference that we are making with the current addiction treatment that we have. And it is really low. In reality, we are not really successful in treatment of addiction. And we have all heard about cognitive deficits among substance users. We have a large cohort of patients in my center, Laureate Institute for Brain Research, that we call T1000, because we are located in Tulsa, Oklahoma. So the name of cohort is T1000. So we recruited 1,000 psychiatric patients, and we followed them. So we did neuroimaging among those people, and we have done lots of baseline assessment, and now we are following them across time, over the time, to see how is their process in the recovery. And we know that those who are substance users, compared to those who have depression, anxiety, and healthy control, they have a significant reduction, or they have a reduced cognitive deficit in different domains, in verbal learning, in inhibition, in attention, working memory, and all these analyses are being controlled for lots of different confounding factors. So we know that cognitive deficit is something significant in substance use disorder. And the other interesting thing about substance use disorder is the cognitive deficit would contribute to the treatment. So if you take a look inside this graph, what you can see is the lower the cognitive functioning, the higher the odds of attrition in the treatment. And those who are doing clinical practice in addiction medicine, they know that when you receive a patient that does not have a reasonable cognitive functioning, does not have enough functioning to be able to have a job, it's really hard to run even a CBT program for them, because they do not understand what you are talking about. They do not have enough memory to be able to keep what you are talking about in their mind and be able to use them. So when they have cognitive deficit, it's really hard to be hopeful about their treatment. And I usually ask from my psychologists that they are doing kind of CBT for the patients, how do you estimate your hope for recovery for a patient in the first visit? And over the time, they realized the most important predictor of the outcome is going to be their cognitive functioning. If they are functioning in their family, if they are functioning in their workplace, if they are functioning well in the society, and it means that they have a reasonable cognitive function. So if they have a reasonable cognitive functioning, the success rate for addiction treatment would be much higher compared to those who do not have a reasonable cognitive function. So we know that cognitive functioning is a really important part of the addiction treatment. But in reality, in the current addiction treatment across the world, we do not do anything for cognitive deficits among substance users. So we do not do anything for brain rehabilitation among substance users. And the idea is, okay, if we let them be abstinent from substances, over the time, the brain would heal by itself. So we just think that, okay, if we keep the brain out of drugs and let them be abstinent for a while, the brain will recover by itself. But in reality, it's not going to happen. Based on different studies that has been done in different sorts of brain injuries, we know that brain healing is a really interesting process, because those who have brain injuries, in different forms of brain injuries, if you let them just to recover by themselves, 1/3 of them would get better over time. 1/3 would remain in the same situation, and 1/3 would just go down. So the brain is not going to recover by itself in many patients, so we need to actively contribute to that. And people realize that in other disciplines, like those who are working in the field of like traumatic brain injury, those who are working with people with TBI patients, they tell you that if you leave a traumatic brain injury patient, a TBI patient, without any rehabilitation, something like 60% of them would not get better, or even they get worse over the time. So that is an interesting kind of process in the brain that, and there are some specific mechanism behind that. That brain has an interesting balance of excitation and inhibition, and sometimes when we lose that balance, without external rehabilitation process, that balance is not going to be back there. So we need to add additional rehabilitation to be able to bring back the brain to the functioning, okay? But the question is, okay, is exercising enough? So the simple idea is, okay, if the brain is impaired and we want to do brain rehabilitation, let's get them some brain exercising. So give them some specific exercise and being hopeful that, okay, over the time their brain would get better. Okay, that is the general idea. But the question is, okay, is just providing them with routine exercise, routine brain exercises, is going to work or not? So that is the question I'm going to discuss about today. And I'm going to discuss about the details and really important minor points that make the difference in being able to run an efficient brain rehabilitation program for addictive disorders. And I think that many of these rules would be applied to other psychiatric disorders as well. So I will discuss at the end that how these things would also be important for those who have mood and anxiety disorders, those who have psychotic problems. So many of these rules would be applied to other psychiatric disorders. So if you are doing clinical practice, not only in addiction medicine, but in other disciplines of psychiatry, I think that there are hopes for other psychiatric disorders as well. Okay, let's start with this example. I'm not sure how many people in the room are able to do juggling like this. Okay, look, how many balls you can do that? 3? How many times? Forever. So awesome, good. So if you are going to claim that you are an expert or pretty much expert in juggling with the balls, you need to be able to use at least 3 balls, and you need to be able to kind of turn them around for at least 3 times. So that is the minimum level of expertise that you need to have to be able to claim yourself as a person who is able to do this game. So let's see that many of the people here are not able to do that. So let's start a program from today. Okay, you will receive 3 of these balls, and then you are supposed to work with them. So you have 1 session per week, 1 60-minute session per week, and you do the exercise with a coach. And then you are supposed to do 30-minute exercises every other day at home. And that is how we start to work with you to be able to do the juggling, okay? But let's see if we can measure the changes with MRI. So the question is, if we do MRI today from you, and then you do juggling practice for 4 weeks, and then we do brain imaging again, can we see any change in your brain that will be detectable by structural MRI scanners? So the level of change that you can see inside the brain with MRI, can we detect that change in the brain or not if you do a practice for 1 month? What do you think? A structural change. A structural change in a macro level that would be seen by MRI. So we are not talking about changes in the synaptic level. And we know that every learning is associated with changes in the synaptic level. We are talking about macro structural changes in a level that could be detected by MRI, with a structural MRI. Do you think it's going to happen or not?
Unlikely.
Unlikely. What are the other kind of expectation from brain change? Do we have that level of expectation from brain to be different in 4 weeks? Does it seem reasonable? I'm going to start to have an idea about what is your expectation from your brain. That is an important step to move forward. Do you expect the brain to be different in 4 weeks of these exercises? Possible. Raul, what do you think?
Sure.
Okay. Robin, what do you think? Maybe. Okay. Muhammad, what do you think? Okay. So we are thinking about, is it possible or not? A group of colleagues in Oxford, they have done that study. And Heidi Johansenberg, she has a lab in Oxford, and she's doing these studies. And they published the results in Nature Neuroscience. They showed that yes, we can. And we can see changes in both gray matter and white matter. So these changes in blue are in white matter, and these changes in red are in gray matter. And there are around an area that we call IPS, or intraparietal sulcus. Where is intraparietal sulcus? Intraparietal sulcus is an area here in your parietal, in the middle of your parietal cortex, that divide your parietal cortex in the superior part and inferior part. Okay, that we call this part as intraparietal sulcus. That is intraparietal. So we see the changes around the intraparietal sulcus. Okay, and the change would be around 4% for the gray matter and around 6% for the white matter. Okay. But what does it mean to have the change around that IPS? Why do we have the change around IPS? Why IPS? Why around that part of the brain? You know that the visual information in your brain would start from the occipital cortex, okay? And then from occipital cortex, information would go forward in the brain. But information in your brain, visual information in your brain, would be divided in 2 main streams. One stream would go down to the temporal cortex. And that stream is kind of named as the what pathway. And the upper stream that would go into the parietal cortex is called where pathway. So processing whatever we have in the visual field, what type of objects that we have in the visual field, is being done in the temporal cortex. But the location of those objects are being processed in the parietal cortex. So we have a what pathway and where pathway. And where pathway would be exactly around these intraparietal sulcus. So the change would be happening in the where pathway and in close relationship with the motor cortex. So it would be something like an area between the visual system and motor system. The area that is responsible for your, basically, hand-eye coordination. So the change is not just a change in the brain. The change happens in a part of the brain that is responsible for that function. So it is not just a random change in a place in the brain. It's a specific change in a specific brain area that is involved when you are doing the practice with juggling. Because in the juggling practice, you need to be able to see places in the right location in the kind of visual field to be able to coordinate your hand and your eye to be able to catch them in the right time, in the right place. Okay? The second question. Are we going to see this change if we ask people to stop practicing juggling for 2 months? If we do imaging in 2 months, what would be the results? If we do imaging after 2 months of stopping doing juggling practice, what are you expecting to see? Are you expecting to see that the change is gone? Or the change is there, or the change is reduced? What do you think? Reduced. But there is still something there, or it would be completely gone?
Just reduced.
Just reduced? Okay. Interestingly, the change in the gray matter would even be increased. Why? Because we know that when we do a practice and when we let people to rest on their practice and sleep over it for a few days, the learned things would just get consolidated in the brain. So sometimes when you give yourself a rest, the rest does not mean that you are going to lose things. Sometimes in the rest, you are just learn things and consolidate what you have learned before in your brain. Okay? And it's a really important lesson for the rehabilitation process. And you can see that when you learn new skills, if you let yourself for a few days, you might even get better because it just gets consolidated in your brain. So we know that the brain is able to change over time. And we know that the change is going to happen in areas that we are targeting with that training. And we know that the change is going to remain there and even get consolidated and be functioning there as well. Okay? So this is what we see in the rehabilitation. But when we are facing a person with substance use disorder, what are our targets? What we are going to target in the recovery process? What are the brain functions that should be targeted? And we know that they have many neurocognitive deficits. Okay? Are we going to target their hand-eye coordination? So is it going to be a good type of practice for them? Is it a function that is important in the process of recovery or not? So we need to answer these questions. What are the functions we are going to target? So it is not just about doing a training for them, a brain training for them. We need to define what are the targets we want to consider and how we are going to use those targets in the process of recovery. So it's really important for us to have an idea about, okay, how the rehabilitation is going to happen. We have started designing a study, a package for neurocognitive rehabilitation for disease of addiction. And we call that package NICO-REDA. And the package is, we named the package for patients as Brain Gym. So when we have been thinking about this package, I was working in developing this package with one of my PhD students, Tara. You can see her name in the first author of the paper, and now she's a faculty member. She has done the PhD and postdoc, and now she's also it goes back to something like 6-7 years ago. So we developed a package, and this is the design of the package. So the package has 16 sessions, okay, from session 1 to session 16. And in each session, we have different sorts of exercises. And the exercises would start from the level 1, and they would go from level 1 to 2, 3, 4. So the exercises are graded. So starting from simple exercises to complex exercises, okay? And they are pretty much distributed. And we have some review sessions. And then we have been targeting attention, visual spatial processing, working memory, verbal skills, and executive functions. So we have been mainly focused to what we call cold cognitive functions. So cognitive functions that are involved in executive functioning, working memory, learning, attention. So we have been targeting these functions, okay? We ran a randomized clinical trial with 120 opioid users. We allocated them in 2 groups, and this is Tara's kind of photo. And we kind of controlled for baseline variables, and then we have done the trial, and then we followed them for 6 months. We saw significant cognitive improvement in the intervention group. So comparing the functions between the active group compared to the sham group, we can see the improvement. And interestingly, some of the cognitive functions would even in the sham group would be even declined over time. So we have done that in the kind of baseline, first month, second month, 3 months follow-up, 6 months follow-up. In terms of retention, there was no difference between groups. It was pretty much disappointing, to be honest. And the retention was absolutely horrible. So as you can see, in the first 2 months, here you can see that, if you can see, this is 8 weeks. So we have been running the rehabilitation in a residential setting for 8 weeks. So, I mean, all the subjects, obviously, it was a residential setting, so they have been there. And after discharge, for 3 months, we have been pretty much successful to follow them. For something like 60% of them were in the follow-up program, because they had a sort of legal obligation for that. And after 3 months, the dropout was significant. And the control group had a more kind of serious dropout, but at the end it was not significant. So when we have been testing, it was not significant. So that was a sort of kind of a negative result for that level. But when we tested the urine drug test for both opiates and amphetamines, those who received the active treatment, they had significant lower positive urine tests, and it was promising. So we published the results in Neuropsychological Rehabilitation, which is one of the best journals in the field, and this is one of the first trials using brain rehabilitation for people with opioid use disorder. So we had reasonable kind of positive results, but we have been thinking that we need to kind of update the program and add a few other things inside. So we started to think about Brain Gym 2.0, thinking about what can we add to what we already have, and how we might be able to promote the program. Yesterday I was talking about brownies and hot chocolate and chocolate cakes, and I'm going to kind of show some of those pictures again to you, kind of just reminding you about what we have been discussing, about brain functions that are involved when we are trying to control our craving to eat something, okay? Whether it's a kind of a really nice brownie or chocolate cheesecake or chocolate cake, whatever. I mean, what are the functions that are involved? What do you think about the functions that are involved when we want to control our craving? What are the brain functions that we like to have when we want to control our brain, our craving to eat something like this?
Inhibition.
Inhibition, right. What else?
Planning.
Planning, okay, good. What else? Memory, good. How can you use your memory for that?
Consequences of when you indulge in that sort of thing.
Okay, good. Yeah, just thinking about, okay, what would be the consequence of using that in the long term? And your previous experience. Sometimes memory would just kind of make things even more complex because you have really good memories of eating such a nice chocolate cake. So, I mean, how you can change those really nice memories that you have with chocolate cake and lots of attachments and love memories with chocolate cake and make new memories about how chocolate cake would basically ruin your heart health. So that is something that, yeah, it would not be easy to do, but yeah. So memory is definitely involved. That level of, let's say, emotional memory. What else? Visual imagery, I do agree. What else? Okay, let's think about how we can target those functions. And then we talk about substance use disorder, that is the case as well. When we are talking about substance use disorder, we have been thinking, okay, how can we develop a specific brain rehabilitation program that can help people to reduce their craving? So how can we help them to improve their self-regulation, to reduce their craving? So, as I told you yesterday, we developed a package to be able to assess craving first and then see how we can do the intervention. And we developed a package for that, a specific brain imaging task, and we use this kind of brain imaging method to see what is happening inside the brain. And we have this tool right now to see what are the parts of the brain that are involved when you show drug-related pictures or we induce craving inside the brain, okay? So we have the measure. So what we are going to do, we are going to do imaging, do the rehabilitation, and do imaging again to see if we can change what is happening inside the brain. So we started to develop Brain Gym 2.0, and for being able to design the package, we needed to have a model. So we started to develop a model that we called Easy Core model. And the Easy Core model, we have been thinking about what are the functions that should be targeted for rehabilitation to help them to be able to have a better self-control. And we know that these functions are being processed in different parts of the brain. And we need to have a sort of a both cognitive and neuro model to be able to target areas and then follow the change over time. So that is what we need to have. So we have started to even think about how we can communicate that complex model to the patients, because we need to get patients involved about what we are going to do for you. So the model is about first environment, discussing about cues and triggers in the environment. And then talking about attention and how attention is getting involved. And what are the different kind of attentional processing involved in eating behavior. And then memory, how different levels of memory is involved. How saliency processing, or what we call appraisal or reappraisal, would be involved. How do we kind of make an interpretation about the signals that we are perceiving? Then interoception, what would be the feeling in our body when we are craving for something? So that is the other important target. And then control, how can we exert executive control to be able to control our craving, and what would be the response there? That is the model that we designed. We call it Easy Core model. And we have the same model for substance use disorder, discussing about, okay, how attention is involved, how memory is involved, how saliency processing is involved, how interoception is involved, how control is involved. And then thinking about, okay, how can we design specific exercises for attention, for memory? How can we change the memory in a process that we call memory reconsolidation? How many of people in the hall have heard about memory reconsolidation? Memory reconsolidation, 1, 2, 3. Okay, 5. Okay, so that is an interesting process that we try to help people to reshape their memories and change the memories that we have, especially memories that basically drive our behavior. And that is a really interesting sort of cognitive intervention. So we have been thinking about what are the specific games and exercises we can design for these functions. So we developed a new program that we called NEAT, Neurocognitive Empowerment for Addiction Treatment. This program has 16 sessions. As you can see in the sessions, we have areas like, let's say, attention, memory and learning, attention, attentional bias. So 1, 2, 3, negative valence, attentional bias, positive valence, interoception, response inhibition, review, then memory, affective memory, prospective memory. When we talk about prospective memory, we talk a lot about mental imagery that you have mentioned, why mental imagery is important. Flexibility, problem solving, decision making, review, and conclusion. So that is the design of the package. And then, this is the architecture of the package. So we start with an introduction. Then we add things about attention, sustained attention, working memory. And then we add flexible attention on the top of that. So we keep the same core and then we add something else. So we call that something like a hierarchical architecture for a cognitive package. And this package is, in terms of the architecture, is different with the first package that I introduced you, the Nico-Reader package. So there are different ways of designing a cognitive rehabilitation package. This is what we call the hierarchical architecture. So then we add interoceptive attention. We add negative attention to what we had before, positive attention, inhibitory control, and then a review, so we give people time to be able to reconsolidate what they had, and then declarative memory, and then kind of emotional memories. And we add things one by one to what we had, and then review session. So that is the design of the entire package. And I have one copy from the package here. That is the package that we provide patients. And it has, the package is designed in a way that each session has one booklet. So each session would have one booklet like this. So we distribute the booklet like this to the patients. And they have 16 pages in each package, in each session. And has 8 pages for the in-class trainings and then 8 pages for their homework. So that is what they receive in each session. And then the next one and next one, this is how we designed the package. And I have this copy for those who might be interested to take a look inside. This is the design of the package, and it's colorful and it's really engaging. And we design everything from scratch, all the cartoons, graphics, everything. And that is the guide. So in each session, we start each session with a scenario, discussing about one sample case would talk about the problems that he or she has with memory, when we are going to talk about memory. And then we ask people to talk about their problems with memory. So they tried, in the first step, we try to get them engaged. When we want to do memory rehabilitation, first of all, they should feel that they need that rehabilitation. So we try to get them engaged. So we have these, let's say, scenarios, and then we have some basic kind of education, we have some tips for them, then we have some games on that specific brain function to help them to learn about that specific function, and then we have a brain box that would discuss what does this game mean, and then we have some notes, what we call the brain plan. So that's the design of each session. And we have something that we call brain planner. So we provide them with a booklet, additional booklet that will be added to their binder, that they have pages to monitor what they are doing in a daily kind of activities. So they are supposed to write down what they are doing, and they are supposed to do some specific exercises in a daily kind of routine that they are supposed to be written in their daily log. So that is another thing that we add for the process. So we try not to just keep the trainings in the session, so we try to give them some things, different things that they are supposed to do while they're at home or in their workplace or out of the class. So this is the design of the brain planner. And when we are designing these packages, there are 10 golden rules that are really important to be considered. First of all, you need to get patients involved and get sure that you have the same goal with your patients and clients. You need to get sure that they really like to be a part of the brain rehabilitation program. So we usually have sort of introductory sessions before starting the program for the entire people in the addiction treatment center, discussing about what we want to do. And we just recruit those who are really interested to make benefit from these programs. And then we do a cognitive assessment before starting the program. And we use that cognitive assessment and we discuss about the deficits that patients would have inside that cognitive assessment to start the program with. So that is really helpful when you have a profile from the patients and you give that profile to the patient and you discuss about, okay, these are the deficits that you already have. So they have a specific goal and they know that we do the cognitive assessment again after the program. So they try to work hard to be able to reach to those goals. So that makes them even more motivated. We need to provide our trainers with some sort of cognitive models. And those cognitive models is really important for them to understand about what we are going to provide in the treatment. So, for example, this is a specific model in terms of, okay, how long-term memory would be happening. What would be the role of attention for memory? Why attention is important? Why working memory is important for the long-term memory? And we train our therapists, and unfortunately most of the psychologists that we receive, they do not have any neuroscience or cognitive background. So we need to train them in terms of, okay, what are the cognitive educations that are going to be important. So we train them for some heuristic cognitive models that are helpful. But I realize that it could be happening in just few days of trainings for psychologists. So they can really catch up things rapidly and they can run the sessions. It's not really a big burden to train them for running the rehabilitation programs. And we use this sort of the same types of heuristic models, not only for patients, not only for trainers, but also for the patients, to provide them with a really golden key term in the field that we call metacognitive awareness. So it's really important for patients to have an understanding about what we are really doing here. And it's really important to have a level of understanding about what is happening inside their brain. We call that cognition over cognition. And we call that metacognition. And metacognitive awareness is going to be really important to what we call transfer effect. Because one of the major challenges with these brain rehabilitation programs is that they get better, but for just doing these exercises that we have in the package. So if you test them with these exercises before and after, they would get better. But there is no change in their real life. If we provide them with, let's say, those computer games, they will just get better for the computer games, but in reality, there is no change in their real life. We really need to transfer those effects to the real life. And if you want to have that transfer from the practice to the real life, they need to understand what does it mean, what those exercises mean, and how should be transferred to the real life. That is the important. How they are going to use these skills when they are facing to a craving-inducing situation. So that is going to be really important. We do the exercises in a graded way. So they should be engaged, and we do that in a group session in a competitive way. So people try to kind of do that kind of faster than the others, and we try to keep the competition in a level that would not just, because there are patients that they are really slower than the others. And you can see that in the session. So you like to keep everybody motivated in the session. And it's not easy to do, but I realized over time that this is something doable if you can keep a balance of doing the games in the session. And the sessions are close to 90 minutes. And I realized that in most of the sessions, it goes really fast because it's really lots of games and engaged. People are just discussing about different things, and they just do not realize that we have been in the session for 90 minutes and the time is up. So it just goes really fast. And that is what I really like about this. It's not really a boring, long, kind of therapy session that people don't like. That is not. And they really like, in the treatment setting, they can miss many other different kind of therapy sessions. But this is not the session that they like to miss. They really like, this is something like a fun game session. Okay, we provide them not only with these materials, we provide them with planners, educational booklets, additional flashcards. We just try to, so this is one of the, for example, flashcards that we give them. So we give them these models, something like flashcards. They can keep these flashcards with themselves. They have flashcards that they can use to be attached to their refrigerator. So there are different additional materials that we provide them. And then, as I told you, the metacognitive transfer is really important. So we provide them with a specific education for each game that how these things are going to make a change in your real life. And we have review sessions. So after each kind of few sessions, we have a review session, and it's going to be important. And we do assessments again. And we try to not to provide them with these kind of exercises for just 16 sessions, but we try to keep these exercises in their real life and help them to change their lifestyle as well. And the last point, we really like to have all of these educations relatable and engaging. How can we make them relatable? We usually start with these sorts of assessments. We provide them with different characters, with cartoons. And we ask them, which one do you like more? Which one do you relate yourself more to it? Okay, which one do you like more? Character 1, 2, or 3? Who likes character 1? Character 1, character 2, character 3. Okay, good. What about these 3 characters? And we designed this specific package I'm going to talk with you just in the Center for Women. And we have a male version and female version. That is another thing that we do. Which one do you like more? Character 1, who likes character 1? Character 2, who likes character 2? Okay. And character 3? Good. And then, this is for character 2. And we like character 2. We receive lots of feedbacks for character 2 because it's really hard to define her race. So just, at least where I work, we have black communities, we have white, and we have Hispanic, so we have different. So it's a type of kind of character that does not have any specific, well-defined race. So then we start to design different sorts of cartoons, think about what are the cartoons could be to make the package more engaging. And then we color them based on the feedback that we receive from patients, discussing about these complex brain functions in a really simple way that they can understand. And we receive feedback. So this is one of the first cartoons that we designed for lack of insight. Okay? People didn't like it, because they have been thinking that the red nose is too much stigmatizing, and didn't like the face very much. So we changed that to this, and they liked it more. They liked it more. So we realized that we need to calibrate those cartoons in minor details to get them more engaging. And then we designed this, and they didn't like that. They were thinking that the face is too much stigmatized. So we designed this. But even this one, people didn't like it very much. Why? Most of the patients that we receive in our center, they do not have family. They do not have a real significant other. So we designed this. and they loved it. So we changed that to this one. So it's really important to consider these minor things, how you are going to bring these sort of cartoons to the practice. And even things, for example, for African American community, we realized that, okay, what are the characters that could be interesting for people in the African American community. So there are always minor details about how you are going to design these packages. So we received a fund from Oklahoma Center for Advancement of Science and Technology, and we started the trial in different addiction treatment centers in Oklahoma. And we are right now in the process of running the trial. So we are almost in the middle of the trial. So we do brain imaging before, we do the rehabilitation for 8 weeks, 2 sessions per week, and we do brain imaging again, and then we follow them for 1 year. So that is the design that we already have. And it is hard to run. There are technical challenges always, but that is one of the trials I really like that I'm running right now. We trained therapists, and I had lots of really nice experiences in terms of how long would it take to train therapists to be able to run these packages. And I've done that before for other packages. This package is much easier and much more engaging for people. So I realized that in probably something like, if you have a therapist in one kind of round of 16 sessions as something like a observer, they can easily kind of get that, and they can run that in the next 6 rounds. So it is not that much complex in terms of the concepts that we are providing. And we run them in group sessions like this. So that is the setting that we have. They sit around a round table, and we use the material. Okay, but one of the things that we received kind of feedbacks that the 16 session is too long. And can we have something shorter? Can we have something that would be kind of because for some of the treatment settings, it's really hard to start with 16 sessions. So they have been thinking that it would be nice if we have a shorter version, and those who are interested, they can come for the longer version. So we started to design what we called brain healing first aid. And this is the package that we have. It is designed to be run for 4 sessions. So we designed that for 4 sessions. And it has 3 main components in each session. So we talk about brain injuries that we have in the process of addiction, drug use, and then talking about how we can help people in the process of recovery. And we designed that based on the RDoC model. I'm not sure if people are kind of familiar with the National Institute of Mental Health, US National Institute of Mental Health, RDoC model. The cognitive kind of model is based on the RDoC model. This is one of the sample kind of sessions that we have. We talk about memory, so we ask people, we usually start with a scenario, a personal scenario about problems with memory that people might experience when they are in the recovery. So we usually start with this, and then we have few exercises. And these exercises are not to train brain, they are just to engage them and let them have a metacognitive awareness about that specific function. So let them realize when we are talking about focused attention, what does focused attention mean? Okay? So take a look at this. I'm going to ask you a question. Okay? Are you ready? Which one was the target? A, B, C, D, E, F. Raul, what was that? I'm going to, yeah. Okay. Which one? B? D? Okay, I'm going to be back. Your memory is important. Yeah, okay. So, which one? Okay, B. So, take a look in this. B, D, right? Okay. the next one. Take a look inside this. Okay, and then we ask questions. I'm not going to ask you questions. I'm not going to test your memory right now and show you the deficits that you might have. But you can see that how much it could be engaging. And we just engage people in a really kind of funny way. And I realize that people really like that. So it's a really kind of engaging. And it's not just to do a memory training here. We just use these games to increase awareness. It's exactly like this. Like when we are talking about your body muscles, when you are talking about, let's say, biceps. When you want to show the bicep muscle to somebody, you need to make a contraction on that muscle to just show that this is your bicep, this is your triceps. And if you want to feel the triceps, if you want to feel the biceps, you need to get that involved. So if you want to let people know what is divided attention, you need to give them a task of divided attention, and then they can feel the pressure on their divided attention, and then you tell them that this is divided attention. And then how divided attention is going to be important for your craving control, and how you are going to use this specific function to be able to control your craving. That is how we designed the metacognitive awareness for these people. And there are some other exercises for this as well. And then we talk about, okay, how you might be able to help your memory, just simple things. And this is going to be happening for just 4 sessions. It's really basic introduction. And even this, I have workshops in my YouTube channel, so if you are interested, you can see how we train our therapists to be able to run these sessions, these kind of simple educational packages. And I'm realizing that people really don't know what is happening inside their brain in the process of recovery. Most of the patients, they really do. And the reality is most of the therapists even, they do not have any idea about what is happening in the brain in the process of recovery. So how can we help people to recover from a drug addiction without having any understanding about how brain recovery is going to happen, okay? And when you go to treatment of kind of diseases like diabetes, when we are talking about diabetes mellitus, you cannot treat any patient with diabetes without providing them with enough information about the mechanism of disease, how the medication is going to work, why they need to do hemoglobin A1C every 3 months. What does hemoglobin A1C mean? You need to provide them with enough information, and without that information, they cannot be really successful in the process of recovery in diabetes or in hypertension or other medical conditions. And we do not do that for drug addiction. That is a reality. So we do not do psychoeducation for addiction. And in reality, we tell people that addiction is a brain disease, but that's it. That is the only information that we communicate. Okay, we tell them that addiction is a brain disease. What else we provide them about this brain disease? Okay, if I have a brain disease, how can I recover from this brain disease? How my brain is going to change in the process of recovery? What are the things I should expect from my brain, or what are the things that I'm not able to expect from? So there are many questions that people have, and we need to provide them through the process of psychoeducation. So we started to think about that, and I told you that I published a textbook about neuroscience for addiction medicine. So we know pretty much a lot about neuroscience of addiction, but we do not communicate that knowledge to patients. So we started to develop what we called Neuroscience-informed psychoeducation, NIPE. And we think that it's going to be an important part of recovery. So we need to provide patients with a good understanding about their brain and the brain in the process of recovery. So that is something that we are right now kind of working. And we have a series of posters for patients discussing about what are the cognitive functions that are involved: attention, memory, decision and control, movement, brain-body connection. So we do not tell them that is interoception. Interoception would be a complex term. So we just say brain-body connection, and why brain-body connection is important. Arousal and sleep, feeling good, feeling bad, social cognition, awareness. These are the functions that we provide them with an understanding about how these functions are impaired and what do they mean for the process of recovery. okay? And we try to provide them with cartoons. And I realized that when we mount these posters in a treatment center, and when you receive a patient from that treatment center, they definitely would remember that they have seen these cartoons before in the treatment center. So all of them would just tell you that I've seen those cartoons before. So they are really engaged. And sometimes they just tell me, okay, that is exactly the feeling that I have. When I want to go to sleep, that is exactly the feeling that I have. They just point to a specific cartoons when they want to explain about themselves, the problems that they feel in the process of recovery. And since then, we have these posters in 12 languages. Because, I mean, there is nothing there. And I told everybody in the field, if you like to have these materials, I would be happy to provide you with whatever you have. And I help them in terms of developing the material in the cultural context of what they are practicing. And we have them right now in different countries, from South Korea to Brazil to China, Israel, Iran, in Arabic version. So we have them in 12 different languages during last 1 year, 14 months. So just seeing that people are interested to have these materials, and we have them in different cultural contexts. And I'm discussing with Caleb right now, discussing how we might be able to have that in other languages. So if people are interested to have this material in other languages, we definitely be happy to help them to develop these materials in other languages as well. But we have discussed about different sorts of materials, how we are putting all these materials in the continuum of care, how we make them as a part of the continuum of care. So I've discussed about posters, brain healing first aid, brain gym. So these are the materials that we have discussed today. I think that the posters could be really helpful in the early recovery, pre-recovery, when we want to engage people in the process of recovery, providing them with hope that your brain is affected by drugs, but it would get better if you provide specific treatment for your brain. And then brain healing and brain gym for early recovery for the next steps. So we have, in US, we have 3 main kind of settings for treatment. We have residential settings. So we provide the brain healing right now in the detox residential setting. So we think that is the right time, because they are in the residential settings for something like 4 to 8 weeks. So that's the time that we provide these 4 sessions. And then we do brain gym in most of the time in transitional living, when they are there for something like 2 to 3 months. And we also use them in the kind of hospitalized setting, in a kind of different version, and also in the office-based setting. So these are the plans that we have for having these packages. And then we realize that we need to, because when they finish the brain gym 2.0, they really like to have an extension. So right now we are working on an extension to help them when they finish the program. If they like to continue the exercises, they should have material for the next steps. And then even in long term. Because I think that the brain rehabilitation is not going to happen without providing them with enough resources for at least 1 year. So we need to provide them with resources for 1 year. It's not going to happen with just few sessions of training. So we need to provide them with the long-term resources. And those who are interested to have more ideas about what we are doing in the field, this is a book chapter that you can kind of, we have published in collaboration with Yale University. We are kind of designing some things with them as well. So that is the resource if you are interested. I will be definitely happy to kind of send you copies if you like to have the book chapter. And okay, few last remaining things. I think that I'm receiving lots of feedbacks from those who are attending in our brain gym sessions that I need to have these educations for my kids as well. I had to receive these educations when I was 16 years old, when I was 15 years old. I didn't know anything about my brain when I was starting to use drugs. And we are realizing that these materials are not going to just be used for people who are in the recovery. We can use these materials for young students, for people who are in their in the middle school, they are in the high school. So we realize we can use this material. So we design a new version of the brain gym for public audience, with removing things related to substance use and just providing education for self-control and self-management. So that is the new version that we have recently developed. So those who are interested to have those methods, that is another thing we are right now working to see how we might be able to run a sort of resiliency program with these education. So that's another thing that we are working on. And we designed a series of cartoons for kids about drugs, how we can discuss about brain and drug in a reasonable way for kids as something like a preventive material. So that's another line of research that we are doing. For those who are interested to work on that line, we definitely will be happy to help them for that another line of research. That is also going to be really interesting, how we communicate with people about brain and drugs. We already have a special issue in Frontiers in Neuroscience on brain and cognition for addiction medicine. Those who are interested, we definitely will be happy to have you there. And also we have a neuroscience interest group in the International Society for Addiction Medicine that we are focused to provide these materials in an international perspective. So those who are interested to join our community, you are definitely welcome. So in the field of cognitive rehabilitation or neuropsychological rehabilitation, there is one of the best textbook in the field is called Neuropsychological Rehabilitation by Barbara Wilson. You can find that easily. So it's been published by Routledge Publication. And we have a chapter on that textbook about neuropsychological rehabilitation for psychiatric disorders in collaboration with Cambridge University. And we discussed in that kind of chapter about what are the targets that we can have in the process of rehabilitation for psychiatric disorders. Today I was mainly focused to substance use disorder, but it's not just about substance use disorder. We can go to other psychiatric disorders. So you can think about how you can provide these educations for other psychiatric disorders. And to be honest, we already have several packages for psychoeducational packages for depression, but almost none of them are really neuroscience informed. They are just really basic information. So neuroscience-informed psychoeducation is an area for many of the different psychiatric disorders. There are really good things about kind of psychotic disorders, but there are still lots of things that people can do if you are interested to that level. So today we have been mainly focused on the cognitive levels and behavioral levels of analysis. And in the first kind of brain gym one, we have been mainly focused on memory and executive functions, but in the next kind of steps, we started with kind of targeting all the other cognitive functions, well, with Brain Gym 2.0. But then the question would be, okay, how we can combine this with what I discussed yesterday about brain stimulation. So adding brain stimulation to this, adding medication to this, how we can provide a combination of medication, brain rehabilitation, and brain stimulation in a model that would put them together in a synergistic way. That is the future of neuroscience for psychiatric disorders. We need to know there are specific medications that basically boost up the effect of stimulation. There are specific medications that they can boost up the effect of cognitive rehabilitation. There are cognitive rehabilitation that they can boost up the effect of some of the medication. So how we can use them in a synergistic way to increase the efficiency of different treatments. One of the most important messages that I really like you to think about after this session, paying more attention to the cognitive deficits that people experience while they are in the recovery. And sometimes we do not take those problems really seriously. They are really important in the process of recovery. We can target those cognitive deficits and we can train them. The training possible if we know how to train them, and we can improve those cognitive functions. If we just neglect them, they're not going to recover. We need to actively work on them. We need to think about metacognitive awareness and how we might be able to provide people with a level of understanding, a level of awareness about their functions. We know that there are definitely great potentials for brain gym for kids, for adolescents. And I think that if they understand about what is happening inside their brain, that is going to be a really good prevention for substance use. So that is going to be really important. I think that level of understanding is going to definitely be helpful. And I think one of the best steps, if you are interested in this field, would be starting to learn how you can assess cognitive deficits among patients. And it's one of the areas that psychologists, they think it's a really complex area to do, doing cognitive assessments. But I've been successful in training psychologists. I mean, they can easily learn that in just few sessions, and they can kind of really, in a well way, they can assess patients for their cognitive deficits. And based on the deficits, that some of the patients, they have severe cognitive deficits, and we can target those patients and help them in the process of recovery. And as I told you yesterday, start this process of brain awareness from yourself. Think about how much you really know about your brain and how much you can improve your brain function. How can you change yourself using your own brain function? And I told you that that is something I try, in a daily way, I try to do that for myself. Something like 2 years ago, I realized that I'm drinking something like 5 cups of black teas every day. And without the black tea, I cannot write my papers, I cannot kind of function really well. So I started to think about, okay, how can I use my understanding as a neuroscientist to stop drinking tea? And it was hard. It was awful. It was really hard to kind of cut down the caffeinated drink. And I started to realize that even there are places that I go routinely in a kind of daily way or in a weekly basis, just because of receiving caffeine there. I just go and grab a specific soda that has lots of caffeine inside. So I go to a Starbucks because of just the caffeine. So, and I realized that even when you take lemonade in Starbucks, they add caffeine to lemonade. Because when they realize if they sell lemonade without caffeine, the lemonade would not be that much attractive to people. If they like to sell lemonade more, they need to add more caffeine inside. I'm not just going to be sued by Starbucks, but you can see that even there are soft drinks that they add caffeine inside. You need to just take a look inside how your behavior is going to be shaped by adding a caffeine in a drink. And I try, there are some non-caffeinated Diet Cokes. I'm not sure have you tried them or not. But if you try them, if you just try the non-caffeinated Diet Coke or Coca Light and caffeinated, I mean the routine one that is they are all caffeinated. Even in the first drinks, I can tell you which one is caffeinated, which one is not caffeinated. So they are totally different. And if you start to drink non-caffeinated one, in just few drinks you realize you don't like to continue drinking that. But when you drink the caffeinated one, you can see, I mean, that is a level of kind of neuroscience understanding about your daily life and how you need to think about your daily life and how you might be able to change yourself. And it was hard. And it could be also true for what I discussed with you in terms of how you can kind of reduce your weight. How can you attach to some activities that could help you to change your eating behavior and reduce your weight. I told you that how I kind of reduced my weight for 50 pounds, and I kept that. I basically, it's something like 4 years, I'm just the same kind of, almost the same weight. And I do the run in a kind of daily way. I mean, in a daily way, I told you that I ran a marathon, and I'm kind of keep running for marathons. And I did the running today in the morning to the center of New Zealand in the morning. It was beautiful. Caleb, it was awesome. It was such a nice place. And I ran from hotel to there and down from there to hotel in less than 30 minutes. And I really love that. And I do that in a kind of routine daily way. So that is what I really recommend people to think about how can you start to change yourself? How can you add 3 miles running every day to your daily life? And that is going to be interesting. And I'm really hopeful that we are going to have a new generation of neurotherapists, those who have a good understanding about different dimensions of brain functions and how we can assess these functions and how can we intervene in these functions with different tools that are available or going to be available in the future. Thank you very much for your attention. I'm here for questions.